So you should see my slides, but I'm going to present them now. Okay, so my name is Aggie. Today we'll go through psychiatric disorders and psychopharmacology. We will cover depression and antidepressant drugs, anxiety and anxiolytic drugs, and schizophrenia and antipsychotic drugs. We will not cover cognitive disorders of old age, eating disorders, drug addiction, and recreational drugs. So starting from depression, as I'm sure you know, we can split it into unipolar and bipolar. I thought these two paintings, both from Van Gogh and both called Starry Night, describe it very well. So see unipolar depression. It looks representative of reality, but perhaps quite sad, whilst bipolar depression, it looks a little bit distorted from reality. So unipolar depression is described as feelings of sadness, hopelessness, and this word anhedonia, which means loss of pleasure. And it's normally treated with antidepressants. Whilst bipolar depression alternates episodes of depression and mania or hypomania, and normally you treat it with antipsychotics and with mood stabilizers. So what are some risk factors for unipolar depression? So we can split them into genetic and environmental broadly. Genetic can be due to serotonin polymorphisms. So genetic changes, for example, in the serotonin transporter gene, and it's got a higher prevalence in females. Whilst for environmental, quite intuitively, if you've had any recent stressful life events or childhood trauma, but also there's been some papers showing links with diet, with the microbiome, and with the immune system. And probably these two genetic and environmental aspects come together in causing unipolar depression by changing neurotransmission and changing neural circuits. So starting from antidepressant drugs, I'm sure you've already seen this paper. It's a seminal paper by Cipriani that was published in The Lancet in 2018. So it was a huge meta-analysis on commonly used antidepressants. It looked at their efficacy, which I've put in this slide, and it also looked at their acceptability, which you can find in the article. So all antidepressants were found to be better than placebo. However, you can see amitriptyline was found to be quite efficacious, whilst reboxetine much less so. Interestingly, as you can see from the size of the square, fluoxetine is one of the most commonly prescribed antidepressants, yet its efficacy is not quite as high as, for example, duloxetine, which is also another commonly prescribed one, although less so than fluoxetine. And I recommend looking at this article so that you can compare efficacy and acceptability, because some of the highly efficacious drugs have low acceptability and vice versa, which matters in a clinical setting for which one would you prescribe. So the targets of antidepressants. So I've put a picture of a synapse there. So to revise a little bit, serotonin is produced from tryptophan, is released into the synapse where it binds to 5-HT receptors. It's reuptaken by the 5-HT reuptake transporter, and then it's metabolized by monoamine oxidase into its metabolites. So looking at drugs, fluoxetine and sertraline are SSRIs, so selective serotonin reuptake inhibitors. So what they do is they act at this reuptake channel to block it, that serotonin stays at the synapse and is not taken back up. Serotonin noradrenaline reuptake inhibitors, so SNRIs like duloxetine, have a very similar action, but they act at the 5-HT reuptake transporter and also at the noradrenaline reuptake transporter. And what's good about them is that often they also help with pain, because noradrenaline is an important aspect of important neurotransmitter in pain. Monoamine oxidase inhibitors act here by preventing the metabolism of 5-HT. So because 5-HT does not get metabolized, more of it stays at the synapse. Examples of those are antidepressants. It's not as clear where they and examples are imipramine and amitriptyline. So starting with the theories of depression. So the monoamine theory of depression is the idea that depression is due to a decrease in monoamine transmission. And just to remind you, serotonin is a monoamine. Evidence for this theory is that drugs which work in depression increase monoamine function. Let's put a paper here. If you remove tryptophan, you increase the risk of depression, which shows that monoamines produced from tryptophan might have a role in depression. And there's evidence that patients with depression have reduced monoamine transmission. And I think this paper is from the Parsi paper. I recommend reading it. But evidence against. So typical antidepressants take weeks to work. So you can see it here. Maybe after 2 weeks is a bit of a decrease, but normally it's said that after 4 weeks, they start to become more efficacious. And this is a very good umbrella review that maybe you've done it in class, but it's a review looking at many studies on the monoamine theory, and they found it to be poorly convincing. I would recommend reading it and getting your own idea because it can be criticized from many points of view, like its choice of studies to be included was quite poor. However, they also bring some good arguments. So yeah, this Moncrief one, I definitely recommend reading it. So role of neuroplasticity. So studies, not quite in humans, have shown that SSRIs increase the numbers of new neurons in the hippocampus, which you can see here. So BRDU is a marker of new neurons, and you can see that with time, the proportion increases in the fluoxetine group, but it does not increase in the vehicle group. And you can also visually see it here that the marked neurons with BRDU increase in numbers in the fluoxetine group. So this potential increase in plasticity is probably mediated by many genes, including BDNF, brain-derived neurotrophic factor, and other neurotrophic factors. When we look at humans, the evidence is perhaps a bit less strong, but still there. For example, they found decreased hippocampal volume in depression. And there's evidence for decreased neurogenesis in depression and fewer synapses. This is in humans as well. So looking at novel treatments, although at this point they've been in the market for quite a bit. For example, ketamine has been on the market since 2019. So novel, but perhaps not so novel. So yeah, ketamine was approved in 2019. It acts at NMDA receptors. We don't quite know how. And it's usually given in the UK as a nasal spray formulation called esketamine. While psilocybin is an agonist at the 5-HT2A receptor, phase 2 clinical trials have found it to be effective, although important to note, this study did not use a placebo. They only compared different concentrations of psilocybin. This is a potential point of criticism from you. And they've been shown to induce neuroplasticity. Any questions on depression, Jay?
There's one question about what was the mechanism of action of the tricyclic antidepressants?
It's not quite known yet, for
Okay.
sure. But what we know is that in general terms, it also increases serotonin at the synapse.
Okay, thanks.
That's the general idea, but the precise one we're still working out.
Yeah, thank you.
Any other questions?
No.
Okay, so for anxiety, they're all the symptoms that would follow increased autonomic nervous system activation. So they're pretty obvious. Tachycardia, so fast heart rate, tremor, pupils would dilate, and you would start sweating. These are the more visible signs. But you could also notice increased vigilance, so just paying more attention and kind of freezing, inhibiting your behavior. So I found this a bit confusing when I studied it myself. There'll be subdivisions, but we'll go through them. So generalized anxiety disorder, so just feeling anxious about anything, any day. Panic disorder, which is a very heightened level of anxiety in some moments, not constantly, normally. Phobias are anxiety directed to something, like social phobia, anxiety directed to social interaction. Separation anxiety disorder, which, as the word says, it's anxiety to separation. Obsessive compulsive disorder, so which is made up of obsessions and like obsessions with something, and compulsions, which are the need to do a certain behavior. And post-traumatic stress disorder, so a type of anxiety that follows trauma. So the biology, I would recommend this review by Medina. Very good. So it's thought to reside in a variety of different places in the brain. So a key one is the amygdala. This is thought to play a role in remembering fears because the amygdala is very important in memory. So its role in anxiety is probably that of remembering something that caused you fear. Then corticostriatal pathways, which are thought to be involved in controlling your impulses. The periaqueductal gray and the midbrain aversion systems, which are probably concerned with defending yourself. The locus coeruleus, which is, where noradrenaline is produced. And the dorsal raphe, which is where serotonin is produced. That's a bit complicated, in my opinion. And if you have a look at this diagram and at the review, I think it makes it a bit clearer, but in general terms, I would remember amygdala, fear memories, PAG, defense mechanisms, locus coeruleus, noradrenaline production, and that would be the essentials. So treatments, this is another review similar to the one that we went through for depression. It's interesting that in anxiety, they put a lot more value into non-pharmacological treatments. So as you can see here, so SNRIs, we've already gone through, selective noradrenaline and serotonin reuptake inhibitors. So they were found to be of high efficacy. But say, for example, here, CBT and drug, we didn't see that for depression, but here we do see cognitive behavioral therapy and drug. Even going a little bit under, we see relaxation, CBT, placebo. So what this tells us is for anxiety, there's a lot bigger role for non-pharmacological treatment. But as you can see here, the most effective ones do seem to be drugs, so SNRIs and benzodiazepines. So starting from GABA potentiators. So GABA is an inhibitory neurotransmitter. GABA A is the target of the anxiolytics. There's a range of GABA receptors like GABA B, but GABA A is the main target. I remember it because A for anxiety. Examples are diazepam, which is a benzodiazepine, which inhibits GABA A, and phenobarbital and barbiturate, which similarly also inhibits GABA channels, stimulates GABA channels, sorry. So we think that if we were able to create an agonist selective for the alpha subunit, we could have fewer side effects because, as you might know, all these GABA potentiators, they make you very sleepy, and they've got a really wide range of side effects that we wouldn't want. Addiction. There's the idea that if we make them selective just for the alpha subunit, we could have an anxiolytic effect, but with fewer side effects. So they've tried doing this, but so far it hasn't been successful. So beta antagonists, common ones like propranolol. So you must remember that these are beta antagonists, whilst alpha-2 antagonists are anxiolytic, anxiogenic. So what's important to remember here is that it's thought that beta antagonists work because fear could be mediated by an increase in noradrenaline neuron firing. And so antagonizing beta receptors could prevent this increase in noradrenaline neuron firing. So this is a great paper. And they activated noradrenergic neurons, and they saw that it leads to anxiety-like behavior. So you can see here the locus coeruleus. They stimulated it with light. They conditioned the animals to, they fired at the neurons in the locus coeruleus when they were in this room. So you see, before the conditioning, the animals spend the same amount of time in the top room as they did in the bottom room. However, after firing the locus coeruleus every time they were in this room, the animals started avoiding it because they got scared of the room, probably. And because the release of noradrenaline from the locus coeruleus got them to avoid the room in which they received the firing. And this is a numerical way in which they assessed it. So preference, we're talking about preference for this room. So you can see that it significantly decreased because the animals started avoiding this room. Do you have any questions about this experiment?
No.
Okay. So antidepressants, interestingly, can also be used in anxiety. SSRIs were found to be effective. It's thought to be because genetic loss of the serotonin transporter can lead to high anxiety, and polymorphisms in the serotonin transporter are a risk factor for anxiety. This is a paper that can show that. But the key debate here is if high serotonin increases anxiety, which is the general thought, or are SSRIs, which also increase serotonin anxiolytic. So Trevor probably went through this with you, but something to think about and something to discuss. So this paper shows polymorphisms in the serotonin transporter. And you can see that having the SS version makes people much more anxious than having the LL version of the serotonin transporter. Questions about anxiety?
Nothing.
We're moving fast, so it won't be too long. So schizophrenia, key symptoms, delusions, hallucinations, and lack of insight. We can divide them into positive symptoms, negative symptoms, and cognitive symptoms. This is essential. Positive symptoms are what you wouldn't think a healthy person would have, but patients with schizophrenia have. So delusions or hallucinations. Negative symptoms is the opposite, is what a healthy person normally has, but people with schizophrenia do not have. So poverty of speech, trouble talking, and anhedonia, which is lack of pleasure doing things. And then cognitive symptoms, so like memory issues and doing cognitive tasks. And it's thought that sometimes the cognitive symptoms might precede the positive and the negative symptoms. So genetics, we know that schizophrenia has a high heritability, which is thought to be 60 to 80%. They think that most of this is explained by SMP, so single nucleotide polymorphisms. However, copy number variants, which are very rare, have much larger effects. So probably both of them have a role in the population. SNPs are very common and all in all explain most of the effect. However, copy number variants, when they are modified, will cause disease, probably. And
What are CNVs?
sorry?
What are the CNVs?
So CNVs are more, you know how SNPs are normal variations in the population?
Yeah.
So CNVs are more serious. Only a much smaller portion of the population would have these mutations, which are normally more extensive than SNP. So sometimes it isn't a base, it might be a series of bases.
Yeah.
And it will be in many, many fewer people that these bases are changed.
Okay, thanks.
So the way I think about them is just they're a step up, they're rarer, and they involve more bases.
Yeah, that makes sense.
So when you look at where the SNPs are, you see that they are distributed around regions involved in synaptic function. So an example is GRIN2A, which, if I remember correctly, is involved with glutamate transmission. And yeah, this paper also recommended one. I remember really enjoying it and really good to quote as well. Let me just have a look at these mutations. So CACNA, you can see many. They concern calcium channels, sodium channels. Yeah, it was quite fun. Something I did before my exams was to have a look at some of those polymorphisms, Google them, see where they targeted, and then that was a nice thing to bring in. But yeah, in general terms, most of these polymorphisms are involved in the functioning of synapses. So the dopamine hypothesis, heard of it plenty. This key graph where the IC50, so how tightly the drug binds to the receptor, is correlated with the clinical dose for controlling schizophrenia. So essentially what it means is that drugs which bind more tightly to the dopamine receptor need to be given at a lower dose for controlling schizophrenia. So it's based on the idea that the positive symptoms are due to too much dopamine, or maybe the same dopamine, but the receptor is being more sensitive. Dopamine blockers, so when you give patients dopamine blockers, they have an antipsychotic effect. Whilst on the other hand, drugs inducing dopamine release, like amphetamine, will lead to psychosis. And this is an example of the amphetamine inducing dopamine release. So they gave patients dopamine, they gave patients amphetamine, they looked at radio-labeled dopamine, and they saw that upon being given amphetamine, more dopamine was released. So to clarify, where I've been a bit unclear, they've noticed that amphetamines increase psychosis. So you have amphetamines, you're more likely to have psychosis. They wondered, why do amphetamines increase psychosis? So they used radio-labeled dopamine so that they can see it on PET scans. And they noticed that, oh, when we give the patients amphetamine, dopamine is released. So maybe dopamine is the thing mediating giving amphetamine and having psychosis. Simple paper, quite good. However, of course, there are issues with this hypothesis. So there is evidence of increased dopamine in the striatum, but similarly, patients with schizophrenia have decreased dopamine in the prefrontal cortex, which led to the hypothesis that increased dopamine in the striatum gives the positive symptoms, and decreased dopamine in the prefrontal cortex leads to the cognitive and the negative symptom. So in schizophrenia, there's probably unbalanced dopamine transmission between the cortical and the striatal areas. So perhaps to do with feedback mechanisms. This is the paper showing prefrontal cortex changes. So in schizophrenia, you can see less dopamine in the dorsolateral prefrontal cortex. The glutamate hypothesis is a parallel hypothesis to the dopamine one, so it's not necessarily an alternative. You can think both of them are true. Maybe they're complementary. So in the glutamate hypothesis, it's based on the idea that NMDA antagonists, like ketamine, worsen the symptoms. When we made mouse models with impaired glutamatergic transmission, we saw schizophrenia-like behavior. So that's telling us that glutamatergic transmission might be important in preventing schizophrenia. This led to the hypothesis that glutamate might be altered in patients with schizophrenia. And the genetic studies, like the one we looked at before, show polymorphisms in some genes involved in glutamate transmission. And further to this, some patients were found to have anti-NMDA antibodies. And as you remember, NMDA is a receptor for glutamatergic transmission. So all these things, pointed at maybe glutamate is involved. So now let's try putting the two hypotheses together, glutamate and dopamine. So what people say is glutamate is trait, dopamine is state. So it's the idea that glutamate is it's the cause of the disease, and dopamine is the manifestation and what brings you the symptoms. This is a hypothesis. Another one is that they are independent. So as you can see here, in here is striatal dopamine synthesis. And you can see that patients who respond to antipsychotics have higher dopamine synthesis. So this makes sense. This is what our dopamine hypothesis is. On the other hand, it shows that treatment-resistant people have increased anterior cingulate cortex glutamate. So this paper points at the idea that there's two categories of patients with schizophrenia. There's patients who have increased dopamine and they're going to respond to antipsychotics. And there's patients who have increased glutamate and they will not respond to antipsychotics because antipsychotics target the dopamine transmission. So yeah, this is an hypothesis in which the glutamate and dopamine are both involved in schizophrenia, but they are independent of each other. And then the neurodevelopmental hypothesis. The base of this is that there are several risk factors for schizophrenia, which are located around birth. So for example, birth complications, birth in cities, infections in the mother. And when they looked at this correlation and hypothesized why, they thought that it could be because they converge at the placenta. So that this birth complications, maternal infection lead to changes in the placenta that can lead to schizophrenia eventually in baby. This could be because the placenta is involved in producing growth factors and neurotransmitters, which in turn might affect the brain, eventually leading to schizophrenia. So on to antipsychotic drugs. Essential to remember that there's typical and atypical. Typical are haloperidol and chlorpromazine. They are D2 receptor antagonists. Whilst atypical, for example, clozapine and risperidone, they're nice because they do not make you very sleepy, so they do not induce catalepsy. And they bind to many more receptors, not just D2, but also 5-HT2A, D3, D4. Another hypothesis on why they do not produce catalepsy is that they block D2 receptors more transiently, and with a lower affinity. So there's two hypotheses as to why they do not produce catalepsy, either because they bind to many more receptors, leading to more complex effects, or because they block D2 receptors for less time and less strongly. And that's it. I've included the link and the QR code for the feedback.